Thanks. Thank you for your cooperation. So I hope everyone enjoyed the lunch. That was really, really good food, isn't it? I really enjoyed it. And lots of discussion this morning, so lots to talk about. This next up is a Pro Talk session. For those of you who have been at partnership conferences before, you know the Pro Talk is sort of a quick and dirty, in, out. We've made a slight adjustment because actually I had an opportunity to talk to Ewan and Teri at the reception last night, and really looking forward to this Pro Talk. So we're going to give them a little bit longer because, well, they need it and they deserve it. So no pressure, guys. So Dr. Ewan Affleck is a practicing physician in Northwest Territories, and he's a health informatician, probably very involved in the CMA and a number of other activities. So many of you are probably familiar with his name. He's also with the College of Physicians and Surgeons of Alberta. Teri Price is the, I should get my executive director of Greg's Wings Projects. And Teri, if you don't know the Greg Price story, you should know. Everybody in this room should know that story. If you don't, please find out about it and make yourself educated around that. It's really, really important. And so they're going to talk to us today about, I want to get the name of the session right. And it's not written in my notes, so I'll let them tell you what they're going to talk about, but it's going to be really interesting, and we look forward to it. So Ewan and Teri, thanks.
So you just, there we go. These work? Mine works?
I think it works. I hope it works. Oh, we're sitting.
No, I'll sit while you start. I can walk. we actually want to body surf. So everyone come.
This is a good start. We knew that we were challenged with staying focused today. We have a lot to talk about. We're really excited to be here and for the invitation. I think we are speaking to a room that probably doesn't need a lot of convincing, but we're going to share a little bit of the work that we've been working on and how we sort of got to this point. And then hopefully this is enough of a teaser for you to reach out and connect with us, which is really what our goal of this session is. So this is my brother, Greg. He born into a family of 5 kids, all healthy kids. We grew up in rural Alberta. Greg went on to be a mechanical engineer. He had his private pilot's license. He was somebody who was super intelligent, he loved to learn, he loved to challenge. And in 2012, 2 days after surgery, he died of a blood clot in my parents' home. The surgery was supposed to be the first step to treatment for testicular cancer. And when he died, our family did what I think a lot of patients and families do, is try to understand what actually happened. And we really wanted to be able to contribute to preventing it from happening again. We had very little interaction with the healthcare system before that. We made a lot of assumptions, but really wanted to contribute to making the healthcare system better. So we had started asking questions. We had sort of different meetings with stakeholders in the healthcare system, and eventually we were introduced to the Health Quality Council of Alberta and a physician named Dr. Ward Flemons. Ward and the team ended up doing an investigation, which resulted in the release of this continuity patient care study. The approach that Ward and the team took was something that we've learned now is fairly unique. It was incredibly important for our family. We were included in the conversations. They recognized that we needed to be a part of the investigation in order for them to really understand what happened. And we learned a lot through that whole process. A number of the recommendations that came out of the report focused on the need for improvement in our health information systems. And Ewan thinks that it may be the only Canadian recorded case where the mismanagement of health information is considered and documented as a contributing factor in Greg's death. A couple years after the release of the report, we had the opportunity to work together again with another team, along with Ward Flemons, to produce the Falling Through the Cracks film. I think it was actually at one of the Infoway conferences. It would have been 5 or 6 years ago, was the first time that we ever shared the trailer for the film. And since then, we've done more than 585 screenings of the film. And really, it's another way that we learn more about the healthcare system, about other people's experiences, whether it's patients and families who share their stories with us, or it's the providers and the healthcare teams in the system sharing what their experience is like. And we are extremely grateful for the opportunity to learn all of those lessons. Through all of this learning, there's been sort of 3 areas of change that we've started to focus on, and where we sort of tend to try and push. We really do believe that care is delivered by teams, that we need a healthcare system that is grounded in teamwork. This will require both systemic shifts, but also a shift in mindset in many cases. Care teams need access to information in order to make safe decisions. We also include patients and their loved ones or family members who they want to include as members of their care team. So when we're saying the care teams need access to the information, we're including patients and families in that discussion. And then the last bucket or priority is really partially because we've recognized how unique the HQCA investigation was, how incredibly important it was for our family, and that truly we need more investigations that can take that systemic look, that can actually identify, instead of it, the whole point of the investigation was to learn the conditions of the system in Greg's case, and not to point fingers at any individual or organization. And it's just been essential for our learning. So one of the main reason why we're here today is to talk a little bit more about what we've been working on more recently. I'm a co-chair along with Ewan of the Alberta Virtual Care coordinating body. And this report, Interoperability Saves Lives, which was released last week, is the latest piece of work that we're pushing out. The working group is a really passionate group of people who are very committed to focusing on some of the challenges in healthcare. And it's made up of a number of people who have likely been working at trying to solve some of these problems for years and years. And I think part of the reason why they're so committed is we've tried to take a little bit of a different approach to the conversation than has been done in the past. And so we're really excited to see some of that engagement and commitment and momentum starting to build. You talk through.
So I'll take over. Oh, am I too loud? Whatever, you can adjust that. Thank you, Teri. So yeah, in the working group, I just want to, so what Teri sort of set things up, what I'm going to do is talk to you about the content of the report, which I really think can complement a lot of the things that are being discussed here. I just want to say, the report, I'm a physician. I do still provide clinical care in the Northwest Territories, so I do my informatics the rest of the country. When I see a patient, if they have a fever, I don't just give Tylenol. I have to figure out if they have meningitis. They may need, if you just give Tylenol, they'll probably die if they have meningitis. So we really set out to diagnose the problem with the fact that Canada has really fallen behind in terms of its capacity to interoperate around health data. And I'm also a member of the Pan-Canadian Health Data Strategy. The work, the charter that everyone refers to actually came from our work in Alberta, and I brought that to the group, and then it got sort of, and so we're very pleased to see that this is moving forward. So what I'm going to do is I'm going to frame the discussion about what we found, right? And this is, what we found isn't necessarily very pretty, right? But it's not, and we analyze Alberta and Canada and compared to Denmark and the United States. This is not an indictment of Alberta. It's not an indictment of the government. It's not an indictment of the physicians. It's just the way we are. And in fact, if we analyze other jurisdictions in Canada, we'll probably find the same thing. Okay? But if you don't diagnose the problem, you can't fix it. So this is where Teri, I first met Teri and Dave many years ago. I found the interoperability, the Health Quality Council report. And I said, wow, this is neat. And I began mapping it. I don't know if neat is the right term, But this illustrates the problem. So let's talk about Greg's case, and we're going to go from the unit of care and look at interoperability through the illustration of his case. So Greg, it was actually 2011. He died in March 2012, but over 407 days, he first went to a clinic about the problem that contributed to his ultimate demise. Then he went to another clinic. And basically what I've done is I've mapped it all. So this is what I call a health information exchange map of Greg's journey over 407 days from the first presentation until his death. So each of these circles is a clinic or a service, but they're also databases. So let's look at these as databases. And the arrows that go between them are the exchange of information about his care, either between him and one of the databases or between the different databases. Okay? So, each of these databases had different technology that held that information. This was in 2011, 2012. Was it an EMR? Was it paper? Whatever. But they were all different, with the exception of the two labs. There's a lab information viewer in Alberta. But other than that, and of course, he had no access to his information at that point in time. So what we chose to call in our report, the connection between these is technical factor interoperability, and we distinguish this from something else, but we'll call that technical factor interoperability. There were 12 different forms of technologies that held his information. So what's the impact of this fragmented system? Well, let's ask that question. Or we can frame it around harm. So this is what we did in our report. We asked the question, what harms arise from this? And if you look internationally, and I'm working with Eric Sutherland and other people, the OECD and so forth, there is nothing called a health data-related harm framework. So we have developed this, and it's in our report. I suggest you look at it, because I think we have to begin establishing the forms of harm. Interoperability can cause harm, or lack of it can cause harm, and it also can be a benefit, but you have to balance these. So what we did is we broke up harm in 3 categories: individual harm, population harm, and system harm. If you go ask ChatGPT about health data-related harm, what comes up? Privacy and security. That's what we all talk about ad nauseum, right? So privacy and security is definitively a harm. It is a problem if we breach information, so forth. But there are other forms of harm. For instance, physical and emotional damage. This happened, Greg Price lost his life. This is damage to his health and well-being, which the Health Quality Council of Alberta documented was related to informational fragmentation. Breach of cultural rights. How many of us, as we procure technologies and use them, consider Indigenous data sovereignty as part of that process over the last 30 years? Put up your hands. Thank you. Oh, there's one. Oh, I went ahead before I was supposed to. Breach of legal and ethical rights. Did Greg own his information? He did not have access to it. Is this better now? Well, what's Infoway's current data? I think it's 36% of Canadians have access to some of their information. A third of a century after the Supreme Court of Canada ruled in 1992 that it belongs to us. That's not very good. Population-based harm, failure to benefit from science and use data for public good. This is why the Pan-Canadian Health Data Strategy was launched, right? Because we perform very badly, because our data is all fragmented and so forth. Use of data to promote population-based discrimination. This is probably not a big thing, but it is a form of harm we need to examine, promote inequities. We certainly see this elsewhere in the world. And then system harm, cost overruns and system inefficiency. Infoway estimates, I think, $2.1 billion a year would be gained if we had comprehensive interoperability. Governments are leeching money because of this. We all are. Harm to health workforce. How does it feel as a clinician or as anyone, a researcher working in this system? I had a patient die on my service in March 2012, 51-year-old. I did not know something about them for 24 hours. Myself and the 4 other physicians involved learnt something. 24 hours later, we rushed this individual to Edmonton from Yellowknife. Emergency surgery, died intraoperatively. How did I feel? I did not sign up for this business to kill people, right? So this, we just simply didn't know. This is a lived reality by all of us. Failure to support innovation, I don't need to explain to you how, health data is the life force of digital health innovation. And often you can't get in. You can't get that information. We're strangling it. So those are forms of harm. In Greg's case, physical and emotional damage, breach of his right to his information. The X's are not lined up there. Are they up there? Oh, they moved. Anyway, moving X's. Cost overruns. Does this look like an efficient system? No, and by the way, I've mapped places in the Yukon, PEI, Calgary since recent years. Things haven't changed much. Harm to workforce well-being. And Teri confirms with me that the individuals involved in Greg's care felt horrible. You just want to quit. We have a health human resource problem. So, what are the determinants of this? How did we get here? How did we get here? That we're harming people through our lack of interoperability. Let's just look at a few things. Governance. Who's in charge of the data in Greg's case? Put up your hand. Anyone? Who's in charge? No one. Exactly, no one. Or many people. Who are those people? Who are the many people? They're custodians. That's who's in charge of data. And it's legislated in Canada. So the legislation we have says people's information will be fragmented between different custodians. So we legislate the fragmentation of health data, which leads to harm. Or you could say we legislate the harm of Canadians very successfully. And remember that. Policy, well, there's no policy harmonization process, right? We do have legislation around health, around privacy. In fact, often health information acts are called privacy legislation, which is odd because that's not the purpose of health information, is to make sure it's private. It's actually to benefit people's health and well-being. The technology conformance, do we ensure that people's technology do we assure that the technology conforms to any interoperability? No, because there is no legislation. We don't have to share information. There are no interoperability standards. Do we assure the people designing these systems are competent to do so? No, it's not a regulated profession. Are physicians, nurses, the leadership literate about this? We really have not been teaching data literacy to professionals and leaders in healthcare, let alone to the public. They largely don't know this is happening unless they become ill. Do we communicate about this? No, because we really haven't talked about it. And we have a culture of service centricity, jurisdictional centricity, and often distrust. So we have big problems. But I actually think the glass is half full. So we call this human factor interoperability. And human factor interoperability is a determinant of technical factor interoperability. How we relate around the data determines whether the technology is going to work. And if we don't get along and we don't agree to have standards and so forth, it's not going to work. You can't buy a blender to fix your marriage problems, let alone a Maserati. But that's what we've done. We've spent billions of dollars trying to fix our lack of interoperability, which is largely a function of we don't work together in order to do that. So we've largely focused on the technical issues. And really, we need to talk about data, because data is what informs our decisions. So this is our matrix of determinants of health data interoperability. You have to consider all of them if you're going to fix this problem, not just the technical ones. And so our work complements Infoway's work, who are largely looking at technical factors, and we are largely looking at the human factors. And so this, in a nutshell, is the whole report. We have determinants of health data interoperability and harm. Our job together is to maximize quality and minimize harm in order to achieve quality care. But if you actually look at the legislative environment, we legislate around one form of harm and ignore the 8 others in Canada. Why? It's nonsensical. That's why I say when I kill you because I don't have your information, at least it will be a private death. So when we do this 13 different ways, right, to add a whole other layer of complexity to the custodial chaos that exists within our jurisdictions. So this is definitively not a person-centric environment. We talk about it, but this is why we talk about person-centricity in the Pan-Canadian Health Data work, because it is an architectural concept. We need to design data around individuals. If Greg's data was designed around him, it would have worked a lot better, because you obligate harmonization of governance, public policy, regulation. So I'm almost done here, and I just want to relate this to the Canada Health Act. We're all accountable to this. If you read the Canada Health Act, it says it's largely about a financial arrangement, but it mentions other barriers to quality care, to the health and well-being of Canadians. If I haven't convinced you that health data integrity and interoperability and our ability is not a barrier, or fragmentation is not a barrier, it is a barrier. It's a huge barrier. So we have an obligation. What did we say in the Pan-Canadian Health Data Strategy? Failure to collaborate across Canada to build learning health systems risks escalation of healthcare costs, underperformance of health services, poor health outcomes, including avoidable illness and death, low levels of innovation, perpetuation of health inequities, and ineffective response to future public health crisis. Sort of lays it out, doesn't it? So what we conclude in our report, we have no choice. This isn't, well, should we be interoperable? We have no choice. It is actually our professional, moral, and ethical obligation to do so. And in fact, the Canada Health Act suggests this. It doesn't suggest it, it demands it. Improvements in healthcare will require cooperative partnerships. Governments, health professionals, voluntary organizations. If we don't cooperate, we're violating the Canada Health Act. Do we have a history of cooperation? Not really, right? In fact, we legislate. So my challenge to you guys, and I'll hand this back to Teri, you can grade 3 things. Read our report. We'll make sure you guys all have it. Number 2, we graded Alberta, but grade your province, grade your territory. You can just go through and click, tick, 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 right? And then join us, right? We are non-aligned. We're just a group of passionate healthcare providers that believe we can do this better. So I'll hand this back to Teri. Thank you kindly.
So there's a QR code for the report and for the link to the website. The website is just albertavirtualcare.org. And I think at the outset, our family really wanted to be able to respond to this question. How do we create conditions for safe, quality, high-performing healthcare? And I think Ewan has done a good job in describing the health information side of the system as being an unstable foundation. There's a lot of room for improvement. We want to see a system that has strong roots, grounded in principles, that is actually recognizing the conditions that we need to create in order to deliver safe care. The Canadian Patient Safety Week, which was a couple of weeks ago, the conversations around, they were trying to shift the conversations around safety to being not just the absence of harm, but how do we create the conditions for safe care? And I think that is an important distinction. I think right now, the healthcare system, we're constantly sort of picking at it, testing it, seeing how far we can push it until it's gonna topple over. And really, we need to recognize how complex the system is and be building an ecosystem that's built on a strong foundation. And I fully believe that having a strong information system that's interoperable, where information can follow the patient, where the information's at the fingertips of the care team, is a critical component of the foundation of that system. So we just added one more point to make around the work that we've been doing with the Alberta Virtual Care Group. To me, it's an example of teamwork at the system level. We've utilized a framework that's called collective impact, which really, the intent of collective impact is to bring together different perspectives that are committed to solving complex problems. And so we won't spend a ton of time on that, but if you're interested more in the model that we've used, I'm gonna click past that because the link doesn't work. If you're interested in that, definitely come and chat with us after. Do you want to go through?
Yeah, I can. So these are just some examples of our recommendations. You know, and I feel like I've beaten you all up. That's not the intention. In fact, after around 30 years in this business, I can say definitively I'm more optimistic now than I ever have been. That panel before lunch was excellent. I'm hearing about movement on the data front, cooperation, standards. Hallelujah. Thank you all. We can do this together, but we just have to properly diagnose this and recognize what is going on. So these are just a few examples of our health data interoperability in Alberta and Canada should be mandated through legislation. We do not feel this is an option. This has to happen. It's not going to cure everything. It's not going to fix everything. And I'll just show you number 13. There are 18 recommendations, but Alberta efforts to modernize provincial health data interoperability should align with national efforts, including but not limited to the efforts of CIHI, the efforts of Infoway, other efforts, right? In other words, we all have to work together. Why should we develop standards, different standards, right? It doesn't really make sense. If we build it around the patient, the individual, we have shared standards.
So we'd like to end the presentation looping back with a picture of Greg. Greg was somebody who did not back down from a challenge. He was somebody who was optimistic, and we are optimistic about the future of the healthcare system. But I like this quote from Melinda Gates that really talks about it's just not a belief that things are going to get better. It's actually having the conviction to make things better. And that's one of the reasons why we've been so grateful to be involved with the Collective Impact Initiative and the Virtual Care Group, because we really do see that collective commitment to having an impact and recognizing that, unfortunately, there's not a single organization or a single person that can just solve these issues, that we do really need to collaborate in order to see and to get to the place where we have a better healthcare system in the future. It really isn't about blaming and shaming. We just need that shared commitment to making things better.
And we're desperate for friendship, and we'll work with anyone. It's true. Thank you very much.